consulted on patient Timothy Blackwell, who is a 39-year-old male who was admitted to the ICU after suspected overdose of an unknown amount of antifreeze. Upon EMS arrival, patient was inebriated, unarousable, and tachycardic with an O2 saturation between 85 and 90%. 4 milligrams of naloxone was given with no improvement. Oxygen was also given en route with max O2 saturation of 92%. Patient reacted slightly to a sternal rub, and upon ED arrival, patient was intubated to protect his airway. Patient has a past medical history significant for depression and suicidal ideation. His mother is deceased at age 65 from suicide. Father is currently living with congestive heart failure and Parkinson's. Patient's current vitals: he has a BP of 191 over 115 with a retake of 195 over 120. His heart rate is 124. His respiratory rate is 14. He is intubated currently. He has a temperature of 38.8 degrees Celsius, and he weighs 125 kilograms. For his review of symptoms, he's unable to follow commands and currently sedated. He has crackles on the left of his lungs. His labs are as follows. His CO2 is 7. His BUN is 18. His creatinine is 2.5. His glucose is 156. His calcium is 5.7. Magnesium 1.2. Partial pressure of CO2 is 18.8. His bicarbonate is 4.2. His partial pressure of oxygen is 222. His INR is 1.19, and he has a creatinine clearance of 50. His procalcitonin level is 2 nanograms per milliliter. He has ethylene glycol level of 33 milligrams per deciliter. His osmolality is 318 milliosmoles per kilogram. His anion gap is 38.2. His osmolar gap is 24. His corrected calcium is 5.86. For our assessment and plan for this patient, he presents with antifreeze overdose. He has an inability to maintain a pH of greater than 7.3 despite the administration of sodium bicarbonate. Our goal is to prevent worsening of metabolic acidosis, enhance toxin elimination, and prevent further kidney damage. We recommend initiating fomepizole with a loading dose of 15 milligrams per kilogram IV, then 10 milligrams per kilogram administered every 4 hours during dialysis, or as a continuous infusion of 1 to 1.5 milligrams per kilogram per hour to treat per AACC guidelines. Fomepizole should be continued until concentrations of ethylene glycol are below 20 milligrams per deciliter. We will DC the sodium bicarbonate infusion and initiate hemodialysis to remove ethylene glycol from the body and correct acidosis. Continue dialysis until ethylene glycol concentrations are less than 20 milligrams per deciliter and the acidosis has resolved. Thiamine and pyroxidine may be administered intravenously to encourage metabolism of ethylene glycol into less harmful metabolites. Doses of both are 100 milligrams IV daily and are continued until intoxication is resolved. If administered before dialysis, additional doses may be needed. Patient is currently in hypertensive emergency. He is tachycardic with a BP of 195 over 120 with worsening renal function and an altered respiratory function. Recommended treat as hypertensive emergency to prevent further complications and potential organ damage. Currently ordered nicardipine 5 milligrams per hour continuous infusion. Titrate nicardipine as needed to reduce the BP following the subsequent parameters. Decrease diastolic blood pressure by 10 to 15% in the first 30 to 60 minutes, then keep patient stable for 30 to 60 minutes. Then decrease blood pressure to 160 over 110 over the next few hours. By 24 to 48 hours, reduce blood pressure to the recommended goal of less than 120 over 80 for this patient per JACC 2017. We'll want to monitor patient's blood pressure and heart rate continuous until patient is stable. His chest x-ray shows lower left lobe infiltrates, which is indicated of lower left lobe pneumonia. His blood and urine cultures are still pending, and his Mercenaries is positive. Per IDSA guidelines, his CURB 65 score is 0. However, he is on a mechanical ventilator, which is indicated of treatment in the ICU. Goals of therapy are to eradicate the infection. For the positive Mercenaries, we're going to initiate Bactroban 2% nasal ointment, applying one half of the tube to one nostril and the other half of the tube to the other nostril twice a day for 5 days. We're going to initiate vancomycin with a loading dose of 15 to 25 milligrams per kilogram IV, followed by 10 to 15 milligrams per kilogram IV every 24 hours for 7 days. We have a target trough of 15 to 20 milligrams per liter. We're going to pull that trough prior to the 4th dose. Initiating also levofloxacin, loading dose of 750 milligrams IV, followed by 500 milligrams IV every 24 hours for 7 days. Initiate Zosyn, 2.25 milligrams IV every 6 hours for 7 days. Going to want to monitor for signs and symptoms of worsening infection, and you can follow up with PCP after discharge. For the patient's depression, his home medication of phenelzine is currently being held inpatient. We're going to discontinue this as it puts the patient at an increased risk of drug interactions. Goal for this patient is to manage depression symptoms and improve quality of life. We're going to want to monitor the patient for signs and symptoms of drug interactions. We're going to refer to psychiatrists for follow-up and long-term therapy with SSRIs. For prophylaxis for this patient, he is currently getting heparin 5,000 units sub-Q 3 times daily for DVT prophylaxis. Goals of therapy for this patient are to prevent any DVTs. We're going to continue heparin 5,000 units sub-Q 3 times daily. Patient is currently intubated and is getting Protonix 40 milligrams IV once daily. Goals are to prevent any GI bleedings and discontinue once patient is breathing on their own again and discharge to medical floor. Thank you.